Our next presentation is titled Caring for Consumers with Mental Health Issues. And we're having a presentation by Ramini, Shankumar, hopefully, Parul, Marwaha, and Elizabeth Scott. Sorry, a late addition, Elizabeth, so welcome. Elizabeth is Director of Allied Health at Monash Children's, and Ramini over the last 25 years has been a driving force in the development of various innovative programs in order to improve the delivery of public oral health services. She has a particular interest in improving the service provision to vulnerable population groups. Parul is a dentist with a specialisation in public health and health and human services management, and has recently received a Monash Health Fellowship to explore the areas of caries management by risk assessment in Aboriginal population. I'd like you to join me in welcoming them to present.
Thank you, Louise, and thank you very much. And I'm really glad we are in the room where Tracy is not here. Just to give you a background, a lot of people don't know what Monash Health. Some people even get confused with the link, Monash Links. We are Monash Health from Monash Health Organisation, and we do have 30 dental chairs across 7 sites. And we have 125 staff at the moment, nearly 55 clinicians. It's a really big service, and we're seeing about 25,000 to 30,000 patients a year. So it's a massive service, and we're always trying to find some innovative things to do. Recently, Monash Health conducted an experience or the culture measure for the whole organisation, and I'm really proud to announce the dental program come up as culture of ambition, so which is really just below the culture of success, but we actually proved to be a culture of ambition within Monash Health. Patient experience is a core value for our dental services, and I just want to share the story with you. A couple of years ago, supported residential services patients weren't accessing the services across Victoria. And there was a pilot project we did, funded by Dental Health Services Victoria, and looking at how we can improve the access. We actually did do successfully the project, and we got ongoing funding from the department, not only for Monash Health, but for Peninsular Health and Gippsland. The model that we used, as you can see, the lady on the right is the Maha worker who's already working within supported residential services, taking patients and improving the access, taking patients to medical services and other services. And also the lady on the very left-hand side next to me is lady from, she's a worker from IRMA, which is the Eastern Regional Mental Health Association. So we tapped into the people who already had developed relationship with these clients and earned their trust. And that really helped us to break the barriers of access, anxiety, all their mental health status to be able to. First year, we actually got 96% of the patients living in SRS being screened, and quite a lot of them needing treatment. But I just wanted to share a story of this gentleman just standing there. We visited a Christmas party last year, organized for supported residential services. While the other clients were having party, dancing, and receiving gifts, this gentleman, he was standing outside the door, and I actually asked the workers there why he was waiting outside, and the answer was that he had a dental appointment at Springwell 2 o'clock and he's waiting for a taxi. That is what I call a success of client experience outcome, not the data, not the other things. It's just a person who was giving up everything and wanting to go for a dental appointment. The next one I wanted to share with you is, again, access. Giving priority access to patients doesn't necessarily mean they're going to come to you and receive care. As you know, pregnant women were given priority access. Across our major hospitals, Monash Medical Centre, Daniel Hospital, Casey Hospital, in 14-15, we got the data, 5,000 women gave birth to babies, and out of that, only 56 women accessed our services, 1%. So we did a research project, and which revealed the barriers were midwifery program, even though the part of Monash Health didn't know that we existed, dental services, there weren't many good referral system. And beyond that, the pregnant women thought that it's bad to have treatment during their pregnancy. In fact, the research shows the other way around. So Monash Health actually gone and developed this poster. All three are my staff at Monash Health, and we actually put it in different languages especially for non-English speaking background clients, to tell them it's safe and it's important to have dental treatment during pregnancy. So these are the learnings that we learned, and we actually going to use it in our project with mental health. Just the third one, very quickly, it's a tool that we have developed to assess the caries risk. We are shifting away from just drilling and filling to look at the risk causing the caries and addressing the caries. At Monash Health, we are looking at a couple of research projects in identifying the caries risk and using the certificate for nurses and the hygienists to improve their health. I'm going to pass it to Elizabeth Scott, who used to work at mental health and now with Monash Health Committee and Alliance. Thank you.
Thanks. Okay, as a physiotherapist, I probably don't need to tell you about the negative impact of mental illness on dental health for many of these following reasons. As well as all of these, the demotivation, the fear, the things that are common to the general population, there's also poor diet, high prevalence of smoking, etc. But I think not only does mental illness have an impact on dental health, but dental health has a really big impact on mental health. And I think a story that clearly illustrates this is a 14-year-old boy that we had in our adolescent psychiatric inpatient unit. He had autism and also had an intellectual disability and had very little verbal capacity. He had severe aggressive behavioural problems. The clinical staff were unsure whether this was due to a psychosis or whether they were purely behavioural problems. He was needing to be managed in the high dependency unit and needed additional staff members every shift to help try and manage his absolutely extreme behaviour. His behaviour could only be managed by multiple additional psychiatric medication. It was eventually discovered, however, that he had a toothache. And once this was managed, his behaviour improved out of sight. He could then engage in his recovery program with the mental health clinicians. His dental history had never been discussed with him or with his family, with the carers. They'd never included it in any assessment. It had never been considered something of relevance. There were enormous emotional and mental health costs both for this young boy and for his family, but also a really significant cost on the health burden on the health costs. Physical health is a really big question for us. Who maintains our mental health consumers' physical health? And it's not just dental health, it's the whole spectrum, and it's something that we're working really hard to address far more. And it was through this, and with this thought in mind, with a very casual conversation with Ramini, that we led to a mutual understanding and commitment to actually trying to do something to better address the dental health needs of our mental health clients. As with all things like this, it's relationships that come about with some of the really innovative and creative projects across different clinical areas. We put together initially some training programs for mental health clinicians to come and talk to the dental health staff, and also Ramini presented to the mental health team leaders about relationships between mental health and oral health and those risks. We developed an aim to identify the oral health risks of consumers, and through a project research grant are in the process of submitting an ethics application to do that. But more than just assessing the risk, what we're really wanting to do is develop tailored health promotion programs for this community and incorporate assessment into standard dental practice, but also incorporate dental screening type questions into all of our physical health assessments for these consumers as well. I'll hand over to Parul for some more details of the project.
Thank you, Elizabeth. So now I will go through some of the methods and what are the anticipated outcomes of the project. So the study design used for this project is the inter-rater reliability study and the criterion validity study. And the inter-rater reliability study will actually tell us the degree of agreement among various clinicians who will be using these tools. The criterion validity is actually a measure of how well a variable or set of variable predicts an outcome based on the information from other variables. For example, in this instance, it will be the extent to which the score on the scale of oral health assessment tool predicts the outcome on ICDAS index. And assuming that the tool has been validated, then we would hope that someone who has scored high or rated as a high-risk patient as per the oral health assessment tool would also score high on the ICDAS index. The suitable participants for the study will be recruited using two main criteria. Firstly, the mental health patients in the secured extended care unit, diagnosed as high-risk patients for oral disease. And secondly, the patients referred by the mental health Dandenong Community Care and Mobile Support Team who are triaged as Category 1 patients by dental intake staff. And the instruments used for this project will be the oral health assessment tool and the International Caries Detection and Assessment System, otherwise known as ICDAS index. And Monash Health Dental Services conducted a literature review in collaboration with Center for Clinical Effectiveness at Monash Health to look for any existing tools for mental health clients, and ended up developing its own version of oral health assessment tool, which Ramini presented before. And the oral health assessment tool will assess the oral health risk of the mental health patients, and the ICDAS will be used for detection of caries severity. And Monash Health has also, in partnership with Melbourne Dental School, University of Melbourne, has trained and calibrated its clinicians and Cert for nurses to use the ICDAS index. So now let's talk about what are we expecting at the end of the project. The immediate outcome would be the validation and assessment of reliability of the oral health assessment tool, as well as the feasibility of incorporating the tool into standard dental practice. And the study will also help identify the oral health risk factors and prevalence of dental caries in the mental health patients. And by completion of the project, it is expected that the tool will assist the clinicians in decision-making and treatment planning based on the identified risks, and it will also give clinicians a better understanding and confidence to deal with mental health clients. And the patients will have improved referral pathways and better access to dental services, leading to better oral health and overall general health. And the patients will also receive tailored health promotion messages based on their identified risks, resulting in satisfied clients who will take responsibility for their own oral health. And the project finally will also assist Cert for nurses to better utilize their skills and knowledge in the field of oral health promotion and disease prevention. It will give them an opportunity to put their learnings into practice. Lastly, I'll talk about the social risk assessment tool and the need for it. A recent research conducted by Monash Health and Monash University found that approximately 60% of the clients attending the Monash Health Refugee Health Service were screened positive for mental health conditions. And as we all know, that refugees and asylum seekers are already one of the higher risk groups for oral health. So to treat the refugees and asylum seekers with mental illness, oral health assessment tool is obviously not sufficient. So Monash Health Dental Services and the Refugee Health team has also developed this social risk assessment tool, which, as the name suggests, will assess the social risks of such clients. The literature clearly tells us that if we do not address the social risk of individuals, even the comprehensive oral health treatment plan will fail, because in many of the cases, the cause of the problem is still not eliminated. And we hope that these tools will help clinicians identify the high-risk clients and that needs immediate attention based on their oral and social risks.
Just before we conclude, I just wanted to acknowledge there are a lot of innovative programs happening at Monash Health, and credit goes to some of the management team come here. So I just wanted you to stand up, the team from Monash Health. Well done. Thank you.
Thank you very much. And I'm sorry I didn't get realise we were blessed with the rest of the team, so I'm glad that we could have that moment to recognise. And I think that from there, once again, we're carrying on that theme, and my take-home lesson from there was about really access and how our experience as clinicians, the experience of individuals, it's about reducing the barriers that are, as they are understood by the patient and or the client, and actually working with them. And I thought it was inspiring to think about how do we have to change our practice, our assessment tools, our workforce to actually deliver in that space. So thank you very much for sharing.